and welcome to this webinar on point-of-care ultrasound in acute care surgery, which is brought to you by ESTES, the European Society for Trauma and Emergency Surgery. We want to make this webinar as interactive as possible, so please ask any questions as we go along through the Q&A button. We'll try to answer them in the webinar either directly through a written message or as part of the panel discussions. If there are a number of similar questions, we may group them together and answer them at the same time. And if you do ask a great question that we don't have time to answer during the webinar, we may send you an email afterwards in response. There'll also be a number of interactive polls during the presentations. All voting will be anonymous, and in most cases, there are no wrong answers. So please don't be reluctant to take part. We'd love to know what you think. We have some great international speakers who, in order of presentations, are Daniel Dumbrava from Bucharest in Romania, who will be talking about point-of-care ultrasound in diverticulitis, Paula Ferrada from Richmond, Virginia, who will tell us about bedside POCUS in the critically ill, Alessia Malagnino from Milan, who will try to answer the question, POCUS, is it cost-effective? There'll also be case presentations by Mauro Zago, Andrea Casamassima from Italy, Ioannis Gerogiannis from the UK. They'll be joined by Isidro Martínez from Spain for panel discussions throughout the webinar. I wouldn't be surprised if some of the webinar team also chip in. So we're going to start with the first case presentation. So I'll now hand over to Mauro Zago for the first case. Maestro, over to you.
Okay, here I am, sorry, I unmute myself. I'm not a maestro and only very fond of ultrasound. Thank you to all the participants and the panelists and the speakers who accepted to be part of this webinar. We hope it could be interesting enough for all of you. So we would like to start with a very common case. You have to deal with a patient, is a male, 73-year-old. He was admitted in the emergency department complaining for left lower quadrant abdominal pain. His medical history is only about hypertension and not insulin-dependent diabetes mellitus. There is a history of non-complicated mild diverticulitis in the past, many used to get rifaximin 1 week per month. On clinical exam, abdomen is plain and there is a localized pain in the area in the left lower quadrant. Mild fever, 37.7 Celsius degrees, no nausea or vomiting. And obviously, you take a sample of blood for lab exam. Now we can start the first poll. I think that, Jonathan, you could start. And the question are, do you need an imaging now? Possible no, because the diagnosis is clear and you only have to wait for lab results, but not in all cases like this one. You always ask CT in this situation or you perform ultrasound. You can try to answer and then Jonathan will comment the results. Oh, there is a prevalence on friends, but someone says that only 12% of the clinical diagnosis is enough. And anyway, around 30% of patients need a CT. We can go ahead. And here, this is the two pictures of the ultrasound was performed first. So you see some very common and specific findings of acute diverticulitis. So the diverticulum with the fecalate inside, with the shadow behind, you see the thickness increased more than 3 to 4 millimeters. You see the hyperechoic fat around the colonic wall, and you see a very small amount of fluid in between. And in the other picture, you have all the signs, all the findings for having a perfect diagnosis of acute diverticulitis. While you are performing the ultrasound, you got the results, and you see there is a slightly increase in white blood cells, and CRP is likely increased after a pain medication. So now what? Do you have you could answer to the poll now Jonathan is launching. So yes, you can decide now to observe and discharge the patient after a significant improvement, because you prefer to admit the patient, or you anyway now need a CT for confirming the diagnosis. So try to answer now. The first two questions depends on the protocol you have for non-complicated diverticulitis in your hospital. And again, there are a kind of conflict between those who prefer to discharge this patient or they feel confident in discharging the patient, and those who prefer to admit the patient, and quite more than 1/3 need a CT. Okay. What happened in this patient? Yes, for you, for the webinar, and even because it's the practice, we had the CT of this patient, and you see on the right side of this, the sigmoid colon with the diverticulum, with the fecalate, and the small collection beside the colon. But this is the point we have to pay attention. But if you try to imagine the picture I presented you about the ultrasound, you can see that it's exactly the same. So you can, mainly in non-complicated acute diverticulitis, the information with CT. So they're increasing the use of ultrasound in this field. But,
Mauro, we lost you in your last slide.
Now,
Mauro, we lost you in your last slide, which I think was leading up to your conclusion. So if you want to just go over that again, that would be very helpful.
sound in Jonathan. Okay. Yes. So did you get this one? Jonathan, did you get this slide? I don't know why it doesn't work.
Okay, do you want to just give the commentary that went with your last slides, because we didn't quite hear what you were saying?
Are you hearing me now?
Perfectly.
Jonathan, go ahead. Yes, this is the only was to tell you that, sorry, the CT was done. The findings were very similar. And if you put to overlap the images, the picture of the CT and the picture of the ultrasound, it was quite the same. And by CT, so sometimes you can skip ultrasound if you are confident in what you are doing. But the possibilities.
Okay, I think that's a very useful take-home message, and I'm sure that with the completely unbiased group that we've got on the panel, that everybody else would probably agree with what you've just said. Is there anybody who wants to dissent from that view? No, I didn't think so.
May I be the devil now? Mauro, it's just a question for you, and maybe from the audience also. I understand that for acute diverticulitis, the use of ultrasound in hands of surgeons depends basically in our skills. So from the point of view of skillful ultrasonographers you are, how many abdominal ultrasound scans do you think a surgeon may need to be proficient in the diagnosis of this Hinchey 1, Hinchey 2 diverticulitis?
So Isidro, good question, very good question. To be honest, I don't know exactly. That you have a probe in your hand, and you can ask the patient if when you compress there is pain there, and this is absolutely a bargain. Let me say, a surgeon performed ultrasound in visceral ultrasound, because this is not something you can get from CT. Moreover, if you are in doubt, for example, and you want to discriminate about between the fluid is how the nature of the fluid is in the belly, you can puncture, is a simple maneuver, and you can discriminate about Hinchey 3, so purulent peritonitis, or only reactive peritoneal fluid, and this can change. For example, if you are able to perform and to get the landmarks and to explore a normal 30 times, okay, maybe you are already skilled enough for at least get a diagnosis. Then it depends about your skills, if you are able to recognize correctly small collection, other more subtle signs of acute diverticulitis.
Okay, Ioannis, you wanted to ask a question or make a comment, I think.
Yeah, I would like to make a comment. Thank you very much, Mauro. What I want to say is that the question about when somebody will be competent to do a specific ultrasound scan, either this will be for diverticulitis or for acute appendicitis or whatever. I think it depends on the country that he's practicing privileges and he's practicing surgery, and what are the local protocols or the national protocols. Because there are some countries that they have specific protocols from the radiologists that you should have a specific number of supervised cases and then do some of them unsupervised. So because we have international audience,
you are right, Ioannis.
And find out what are the local protocols, and then see, of course, how many cases he can do alone and be competent to do a specific case. So it's a little bit tricky. But of course, by practicing and having more experience every day, you can do an ultrasound scan and help your daily practice.
Of course, that's the difference between competence and certification.
Exactly.
Okay, good. Shall we move on to Daniel, to your talk?
Yeah, sure.
And take things a little bit further.
Okay. You can see my screen, yes?
Yep.
Okay, so I'm going to talk about POCUS and acute diverticulitis. So just an overview after Mauro's case. So 1 second, yeah. So in terms of general concepts, so diverticuli are herniations of colonic layers through a weakened colonic wall. They're either true or false. So basically, true diverticuli involve all the layers of the colon and are mostly met on the right side, and especially in Asian population. And false diverticuli, in which only mucosa and the submucosa are protruding through the muscular layer. And they're usually on the left colon, in the sigmoid colon, and they're more prone to complications. So in terms of epidemiology, diverticulosis, so not the acute diverticulitis, just diverticulosis alone affects about 65% of over 65-year-olds and only 1/4 of patients over 40s. And of these patients, only 25% will actually have acute diverticulitis, and of those cases with acute diverticulitis, 90%, so mostly will have an indolent course, and only 10% will have complications, of which less than 6% will require emergency surgery. So that percentage needs to be memorized, and the recurrence risk is it's lower than you might expect. So new studies suggest between 13 and 23%. And the recurrence risk is defined as relapse after 12 weeks. In terms of diagnosis, clinical evaluation has a very low sensitivity. So just like Mauro said, we have the classical triad of left iliac fossa pain with elevated inflammatory markers. And the current standard is to do a CT scan. I'm not saying the gold standard, but just the imaging standard, because in fact, the diagnosis will be made by histology, but obviously we can't make a colonoscopy in an acute inflammation. CT comes at some costs in terms of radiation, hospital costs, and limited availability, especially in countries like UK and Ireland, where sometimes there might be problems in terms of out of hours radiology availability. And even so, only the CT scan will change management in only 7% of cases. We're all familiar with the Hinchey classification, but in clinical practice, we only need to remember of two instances: the well patient, so Hinchey 0 to 1A, 1B, and the unwell patient of Hinchey more than 2. So what are the benefits of CT scan? The CT scan has better specificity. It's essential for the critically ill. As a single test, studies show that it's better than ultrasound. And obviously, it's very good for differential diagnosis, which I'll talk about later. But even so, CT scan can overestimate or underestimate the stages of diverticulitis, just like a few studies show. So there comes the question, is CT overkill in a complicated disease? Now I'm just putting here the numbers that I've highlighted in previous slides, that CT will change management in only 7% of cases, and less than 6% of patients with acute diverticulitis will actually need surgery. So why should we do POCUS in acute diverticulitis? So first of all, we need to see ultrasound as an extension of the clinical examination, as a technologically third hand that might fill the gap between the clinical examination with its low sensitivity and CT scan with its costs and radiation exposure. It's readily available at the bedside, and due to the fact that inflammation is a dynamic process and there might be a need for repeated exams, we can make POCUS over and all over again. We can repeat it anytime we want. Let's talk about the technique in general aspects. So we started from general abdominal examination with a panoramic view with a curved array. And then after we've done the whole abdominal examination to see if there's any free fluid or if there's any other problems or a quick differential, then we switch to a linear probe and focus on the left iliac fossa. And we are searching for the normal gut signature, that is the histological layers that we will be seeing on ultrasound. Actually, Mauro's pictures were very nice with fine details. Probably the ultrasound machine was the newer generation. What would be the POCUS features in acute diverticulitis? So the first to describe the ultrasound features was Porlecker in 1985, and he described it as a target sign or as a pseudokidney appearance. And then those features were described in further studies, and we actually had our POCUS census meeting in Valencia in 2018. And there are five features that we need to look after, of which at least two of them are mandatory. That is the thickened hypoechoic wall, the pericholic fat changes, pain and graded compression, and then the diverticuli and features of complications. So let's go through those. So the thick hypoechoic wall, which is a mandatory sign in most studies, which is described as thickening of more than 4 millimeters on transverse view of the bowel wall, on at least 4 centimeters in longitudinal view. So this hypoechoic wall resembles the hypertrophy of the muscular layer. Then there's the hyperechoic surrounding fat, or the fat stranding, which comes due to inflammation and increased vascularity. The pain on graded compression resembles the sonographic Murphy sign, and it was initially described in appendicitis as well on the right side. And then there's the presence of diverticuli. Hollweger in 2009 described extensively the presence of diverticuli in a study. And he only found that the diverticuli will be present in 50% of cases. But if you find a diverticuli, then the sensitivity of the examination increases to 96%. They might be the only feature on the right side, and they're described as either hypoechoic or hyperechoic if there's a fecality in there with a posterior acoustic shadowing, just like Mauro showed in his presentation. And then other features would be the absence of the peristaltis, so the loss of compressibility, just like in appendicitis. This will be evaluated when addressing the mural thickness. And then we can see the features of complications, such as abscesses, fistulae, and pelvic free fluid. We can also look after the Doppler signal, which will be increased because there's hypervascularity in inflammation. This is a slide, it's a courtesy from one of my colleagues in my hospital with a complicated disease. So we can see an abscess cavity on the left side, and then we injected contrast. So we've done an ultrasound with contrast enhanced, And then you can see, and then we've drained this abscess. You can see here on the right side of the screen here, the tract of the drain, just as the management of a complicated disease. So what would be the differential diagnosis? So here is where combining POCUS and the clinical examination helps. So the differential will be with Crohn's disease. On ultrasound, you can see full thickness of bowel wall involvement. But if you do ultrasound further, you can see that the involvement is in the small bowel as well. And then you have a young patient with perianal disease or with bouts of diarrhea, more than you might expect in diverticulitis. For bowel malignancy, this is the tricky part. Usually there's a stenosis of the bowel lumen, but here is one of the indications where when you have a patient with weight loss, then you might need to do the CT scan to convince yourself there's no malignancy. I've had a few cases where there was a patient with multiple bouts of acute diverticulitis, but in the end it was actually perforated bowel malignancy with superimposed diverticulitis as well. Then is ischemic colitis in an elderly patient with atherosclerosis. You might have absence of peristaltis and decreased vascularity on Doppler ultrasound. And then gynecology pathology, you can see ovarian cysts, or they usually come in young female. So diverticulitis in the young would be something more rare anyway. So is POCUS myth or reality? Despite of the fact that ultrasound for acute diverticulitis was described in 1985 and then in the early 90s, the first big studies were actually done in 2007 and 2008 in Örebro University and then in Holland. And then they found that there was no difference between CT scan and ultrasound in terms of accuracy. But those studies were limited, that they were only looking after certain features, so pain ungraded compression or just presence of the diverticuli. So not all the features that I've described earlier combined. And then the later studies and with subsequent consensus meetings like the World Society of Emergency Surgical Guidelines and Italian consensus conferences, they are using, or they are recommending a step-up approach. So you do the clinical examination, then do the POCUS, and then if you're in doubt, then do a CT scan. So basically use POCUS to fill the gap between the clinical examination and the CT scan. And then we had our consensus meeting where we asked a few PICO questions. And before that, we ran a poll between acute care surgeons that are using ultrasound, and most of were in favor of using ultrasound in acute diverticulitis. And it was interesting that most of them found it more appropriate for complicated cases and not for uncomplicated cases. And then this is my own study, which I'm hoping to publish this year, now that maybe COVID is not taking the front stage. The point of care ultrasound by surgeons, where I've demonstrated in 45 patients a sensitivity of 100% compared to CT scan, and with a moderate agreement between radiology and POCUS. But then the time frame from my ultrasounds to CT scan being a mean time of about 9 hours. So in conclusion, is it a myth or reality? Well, I think it's reality. It's a technological third hand, the new stethoscope, which helps in real-time evaluation. It may decrease costs and radiation exposure. There are multiple studies that measured the radiation doses and the costs. It might help to fast-track patients, either complicated disease and non-complicated disease. And even though it requires experience, well, all surgical procedures require experience. Endoscopy requires experience, but it still needs to be debated. Thank you. If you have any questions.
Thank you, Jan, for that great presentation. Can I ask you what to me is probably slightly devil's advocate, the question being, you told us that CT scan is only really useful in changing your management in 7% of cases. And therefore, really there's not that much point in using CT for those other 93%. What's the point of using POCUS? Because presumably if it's equivalent, you'll still only change your management in 7% of cases. Or are you selective in how you use it?
Yeah, so I think that for uncomplicated disease, when you have a patient that comes with uncomplicated diverticulitis, which you can send home and then see back in outpatients and then in 6 to 8 weeks colonoscopy, I think that's where POCUS would help. Especially if there are patients who have multiple bouts of diverticulitis or have rare episodes of acute flare-ups. They can come to the emergency department, you see them, do a POCUS, see there's no abscesses, see there's no signs of complications like free fluid. And I think that for uncomplicated disease, ultrasound would be of more of a benefit. There are actually studies that show, there was a Japanese study that showed a very good outcomes in discharging patients after ultrasound and then follow them up in OPD with ultrasound as well for right-sided diverticulitis. It's a study from in 2008 by Mitsuki. I have some great literature recommendations for that.
Yeah, any of the other panel want to comment? In which case, let's move on, Andrea, to your case presentation. Andrea and Olivia.
Thank you.
Good evening.
Okay, so we're going to talk about the use of RASH, which is the rapid ultrasound in shock, therefore patients who experience shock. We're going to start with 2 clinical cases. Our first patient is Mrs. Smith. She's a 94-year-old woman who suffers from hypertension, COPD, and hypothyroidism. And on the other hand, we have Mrs. Marple, who is 94 years old, suffers from hypertension, and has a clinical history of atrial fibrillation and mechanical valve, mitral valve placement. Both women were found on the floor, and they accessed the ER in shock. Mrs. Smith is tachypneic, cyanotic, agitated. Her blood pressure is 80/50, her heart rate is 110, respiratory rate 32, and saturation 90%. Whilst Mrs. Marple is tachypneic as well, she's pale, agitated, and her parameters are more or less the same as Mrs. Smith.
Quite common findings in our emergency departments, as well as in yours, I think.
So, a question for you now. What exams would you ask for if you were to visit these patients? Blood tests, chest X-ray, and ECG and ultrasound, or blood test, arterial blood gas analysis, ECG and CT, blood test, chest X-ray, arterial blood gas analysis, ECG and ultrasound, or blood test, chest X-ray, ECG, ultrasound, and CT. Okay, so the majority of people replied
an ultrasound.
Okay.
Why? Because it's a webinar ultrasound maybe, or it's really useful. Let's go and find it.
I think most people want an ultrasound and arterial blood gases, because you have given the option of ultrasound twice.
Yeah, fair enough. So that's what we did. We asked for blood tests, chest X-rays, arterial blood gas analysis, an ECG, and in the meantime, whilst waiting for the results of these exams to arrive, we perform ultrasound. So patients, Mrs. Marple, we look at the pump, so her heart, and what we see here is hypercontractility. Then we go look for the same thing in Mrs. Smith, and again, as you can see here, or maybe
you should see
again hypercontractility.
So no difference between two patients.
Between the two of them. Oh. Okay, maybe no. Okay, but the interesting thing in this case is her cardiac ultrasounds, which you should be able to see. Okay, there we go. You can see here. And the question is, what can you see?
Is it a normal cardiac image in ultrasound? Is there something strange in it?
So it can either be left ventricular hypertrophy, right heart strain, cardiac tamponade, or regional wall motion abnormalities.
Like in myocardial infarction, maybe.
So, time for you to vote. Okay, so everyone's voted. The majority of you chose cardiac tamponade. Interesting. But what we actually have here, as you can see, it's signs of right heart strain. So we have the so-called D signs with a paradoxical bowing of the interventricular septum towards the left ventricle because of right volume overload. Then again, we move on. We move on to look for the pipes, which means inferior vena cava for Mrs. Marple. So you should be able to see in the video, which doesn't actually work now. Okay, just give us a second.
Powerful PC on hospital. Give us some quirks.
So basically what happens in the ultrasound of Mrs. Marple is that we look for the inferior vena cava and we look at its inspiratory variations. In her case, the inferior vena cava collapses upon inspiration, which is a sign of low volume load. And hopefully we'll be able to put it up again for you.
Okay, sorry for the technical problem.
We're trying to sort
Just
it.
crashed.
Okay, so you cannot see right now, but just trust me. That's what we find in Mrs. Marple, inferior vena cava. So it's an inferior vena cava that collapses upon inspiration. Then we look for the same thing, meaning the pipes, so the tank, the inferior vena cava of Mrs. Smith. And on the other hand, Mrs. Smith inferior vena cava does not change upon respirations. It's a so-called plethoric inferior vena cava, which means that it doesn't move and it's a sign of volume overload. Okay. We're trying to resume it for you. Okay, so after looking for the inferior vena cava, what we can do is to perform rapid ultrasounds in the so-called 3 quadrants, which are the right upper quadrant, left upper quadrant, and in the pelvic area. So in case of Mrs. Marple, who was the patient with a collapsed inferior vena cava, which meant a sign of decreased volume load. In the case of Miss Marple, we can see that there is fluid. Here's the liver, the kidney, and you can see fluid in the Morrison's pouch. While looking at the left upper quadrant, we also see fluid in the whole perisplenic space. And then,
Olivia, are you sharing your screen?
What's interesting is at this point we look for can you see it?
Is it working?
Can you see the presentation?
No.
Okay, perfect.
You have to share the screen. We are seeing you and yeah.
Just bad connection here in Melzo. Yeah. We're very sorry for it. We're trying to sort it. Okay.
I can't bring up the screen sharing. All I can do is try and leave and go inside again. Oh,
Jonathan, I have a suggestion. As we know that Paula Ferrada is talking about similar topics, so in a more didactic and not interactive way, we could move ahead with her presentation and then ask eventually to Andrea and Julia to present or to go to the end of the case. Okay.
Okay, we'll do that. Paula, your presentation is just about to begin.
Hello, thank you so much for the kind invitation. In the next few minutes, we're going to talk about my perspective of why bedside point of care ultrasound is important in the critically ill and what can we get from it. My name is Paula Ferrada. I'm a professor of surgery at Virginia Commonwealth University. I direct the intensive care unit for surgical and trauma as well as the critical care fellowship. I have no disclosures in the sense that nobody pays me to say what I'm going to say, but by the end of the talk, you will understand that I am really enthusiastic about ultrasound. So I have my personal bias towards using ultrasound. So we have a patient that is hypertensive, and intuitive thing to do to this patient is to give IV fluids. This is how the trauma bed looks here at Virginia Commonwealth University. And I'm gonna guess that it's also how it looks in many places where there's a lot of resources. There's somebody looking at the airway, there's somebody else already doing primary and secondary survey all together as one team, right? But we all know that that's not how the emergency room looks in every place. And if we have an ultrasound, we can bring the gold standard of care to that patient that needs it the most, that they don't have, where they don't have anything else, but an ultrasound machine and a human resource that can help these patients survive. So we trained with echocardiogram, looking at the heart for fluid status and causes of hypertension. We created a training program that was a very short training program for oral trauma surgeons. That's why it says it's so easy, any trauma attending can do it. Then we measure how long it will take the people to perform the test. And we asked the cardiologist to also perform formal echocardiogram, and we correlated 100%. They were blinded to our results, and so were we, and the correlation was 100%, and the lactate was decreased in all patients that we guided therapy with these tests. This is the screenshot of the lactates. Then we decided to bring it to the trauma bay, because sick people can be in the trauma bay, can be in the ICU, can be in the floor, can be in the anesthesia unit, they can be everywhere. And we found that the majority of them look hypovolemic in the echocardiogram, but some of them were not. And strikingly, in patients older than 65 years old, the limited echocardiogram changed therapy in 96% of the cases. So then we decided to do a randomized control trial, and we did these limited echocardiogram in days, in some days, and some other days we did not do it. And we found that patients that got a limited echocardiogram, they had less IV fluids, less time they spend in the trauma bay when going to the operating room. They have a higher chance of being admitted to the ICU, and the mortality, not statistically significant, but lower, from almost 20% to 11%. Now, because here at Virginia Commonwealth University, traumatic brain injury is 1/3 of our admissions, but more than half of our mortalities, we did a subgroup analysis. And we found out that we also give less blood, gave less fluids, spend less time in the waiting to go to the operating room. And what was more notorious is that the mortality from almost 40% decreased to 15%. Now, am I saying that a point of care ultrasound, specifically echocardiogram, saves patients' life? No, but intensivists, surgeons, emergency medicine physicians, people that are providing care for these patients with a brain and more information can save patients' lives. This is an example. This patient, let's say this patient is hypotensive, and this is a view of the IVC. It's almost completely collapsing. This patient needs IV fluids. This patient is hypovolemic. Versus this patient, the IVC is completely plethoric. This patient does not need IV fluids. The cause of hypertension will not be hypovolemia. This patient was an elderly patient that came to a trauma bay, already has a pleural effusion, as you can see as well. In our experience, you don't need esoteric measurements to know if an IVC is flat or if it's full. As you can see, an educated eye, an educated visual gestalt can tell you if that patient needs IV fluids or not. Let's take a look at contractility. So this patient, as you can see, the heart is moving fast, but look inside the ventricle and look how actually it's not really collapsing. This is another example. This is another view. This is a short axis in the apical muscles. And you can see how it's really not closing very well. If this patient is hypotensive, the cause is not only not hypovolemia, but you know that the pump, the heart, is not working well. This is another case, completely different. This is the left ventricle. As you can see, the left ventricle is completely empty, but also there's this very large pericardial effusion. This patient has two reasons of hypertension. Number one, he has an injury to the right ventricle that has decompressed into a pleura. So you can see that the heart is completely empty, not only has tamponade, but also hypovolemia. This is another interesting case. This patient had multiple orthopedic injuries, was in the floor. They were evaluating him for rehab and missed a few DVT prophylaxis doses and was hypertensive. And I'm going to orient you. This is the left ventricle. This is the right ventricle, right atrium. And as you can see, there's something inside the right ventricle and atrium. This patient had a pulmonary emboli that was diagnosed by us using limited echocardiogram. Went to the operating room, got the clot removed, and perhaps potentially we saved time in not doing a CTA. We saved time in not doing any other procedures that were necessary. This is a patient that was in the cardiac unit. Mediastinal tubes were removed. Patient was hypotensive. He had a Swan Ganz and the wedge pressure was increasing as well as the CVP. And as you can see, not only you can see the pericardial effusion, but also the beginning of clot formation in the pericardium. Patient went to the operating room, had the blood clot removed, and did better. Now, X-rays are not very good at diagnosing much in patients. This patient came to a trauma bay, had pleuritic chest pain, and blood pressure was soft, not too hypotensive, but systolic blood pressure in the 90s. And as you can see, this is something that we call lung point. From here to here, the lung is moving appropriately. From here to here, there's no lung movement. This is just air, A-lines. We did not put a chest tube yet, but after the chest CT scan, as you can see, our ultrasound probe was basically right here in between pneumothorax and non-pneumothorax. Patient got a chest tube. As you could see before comparison with the chest x-ray was not very good at diagnosing pneumothorax. This is a somebody that was in the ICU. We don't know if that was a collapsed lung or pleural effusion. We did an ultrasound. And as you can see, this is the lung bathing in fluid, is a pleural effusion, is a chest tube. We also use it for the trauma bay. Patients that come in coding with loss of vital signs. Here you can see that there's absolutely no meaningful cardiac activity. All the movement that you see is only in the valves. These patients, in our experience, that lost vital signs before it came to us doing chest compressions, and this is what we get, we will not resuscitate this patient. This is what we call a still heart, and there's plenty of literature suggesting that mortality is 100%. Patient is already dead, and when you have these secondary to trauma, this is an irrecoverable situation. We have done over 4,000 echocardiograms in our units by intensivists, and I'm talking about everybody. Advanced care providers, residents, fellows, attendings, all of us together is as one team. And we took that course that I told you about, and through the Pan American Trauma Society and the American College of Surgeons, we have been able to give that course to multiple people in many places of North, Central, and South America. We have been able to train anesthesiologists, surgeons, paramedics, nurses, nurse practitioners, anybody that can really want to learn, can learn this skill. In conclusion, this is how the stethoscope used to look in the 1800s. And then in the 1960s, Dr. Lindman, who was a physiology professor at Harvard, made it into something similar to what we use today. And for more than 50 years, we have been using the same tool to help diagnose patients. And perhaps it's time that we make a change. In my perspective, ultrasound, point of care ultrasound for intensive care unit is teachable, repeatable, gives you immediate information, and you definitely can do it. I haven't met anybody that cannot be trained in this. The only obstacle that you have to become good at this is yourself. Thank you so much for your time. It has been a pleasure to be here with you today.
Thank you, Paula.
Thank you for the opportunity.
We have an echo. Maybe there is someone connected 2 times with 2 devices. I don't know who could be. Jonathan, are you there?
Yeah, sure.
So I have, if I can, I have a question for Paula. Thank you for your fantastic presentation, and which is very stimulating, but at least in Europe, very difficult to realize, because we know that the heart is far from the mind of the vast majority of general and fair of cardiologists. What I would like department and intensive care unit for mainly traumatized patients, but I think that there is room for using this kind of applications, even we are facing, for example, for complications, even suspected septic patients. Do you have any experience on that, or do you have some suggestion for us?
I don't. I could not understand the question because there was too much interruption in the internet, but I can tell you that I agree it's important to have collaboration. The only way that we have been able to do this is because we have collaborated with the cardiologist, with the emergency medicine physician, with other intensivists, that you have to create a peer pressure environment where no IV fluids, no pressors, no Lasix gets given without having an image. And you have to have a champion, somebody that you have to have a champion for a fellow, for residents at every level, and somebody that will push people, like positive peer pressure to get it done. Otherwise, it dies. If it's depending on one person, that it becomes an impossible task to do. But I shared, I'm going to share my email via the chat in case there's any other questions. I know the connection has not been great, but this is one of my passions. And as you can see, we have produced about a dozen of papers from Virginia Commonwealth University, and we have some experience doing it, and we will love to help anybody that wants to get more involved with it. I know in Europe, this is a thing. Every surgeon knows how to use ultrasound. I think we just need to make sure, like we just need to popularize it and support people that are trying to create these programs.
May I ask a question? Paula, do you hear me well?
I can hear you perfect.
Okay, just congratulations first. And then I would like to comment because I've been reading, I have no experience in point of care ultrasound in shock, but I have been reading some results from other studies. Like, for example, there's one in the University of Arizona. It's a retrospective trial with about 5,000 shock patients, and they found that there was an association in performing the point of care ultrasound, in not performing them or performing the point of care ultrasound before and after the initial measures to resuscitate the shock. And they found there was an association among performing the point of care ultrasound and mortality. They could not find the reason for that, but they mentioned there could be a diminish in the aggressiveness of which we confront the response to these patients, the resuscitation of these patients when we perform the point of care ultrasound, or maybe we can delay the intervention. I don't know what's your opinion on that.
I have not. I have not read that article particularly, but I can tell you in the United States, there are many people like us that are doing point of care ultrasound in the ICU, in the trauma bay, in the floor. And I think as everything is operator depending, like you can then publish an article saying that exploratory laparotomies in your hand increase mortality. Well, you have to go there and take a look and see how you're performing them. I agree. Mm-hmm. It should be a tool to help you treat the patient. It should not be something that delays care. Complete agreement on that. I will have to ask the authors, how do they perform it? When did they perform it? Why did they perform it? What is their experience of their training, and who's overseeing the program before you say that increases mortality? I know I discussed a paper for the American Association of the Surgery of Trauma last September of a group that actually found that in elderly people, it helps and it changes therapy the same way that we did it. It's very similar to what Dr. Tom Scalia described many years ago when he was in New York, describing that swan guns actually help the elderly people. I think it's a matter of having more information about fluid status and pattern of injury. I don't think that anything, for that matter, if we're gonna go to crazy discussing new technologies, Reboa, ear thoracotomies, laparotomy, ultrasound, none of that can be taken out of isolation. You have to take a look in the context. So long answer to the question. I believe that more knowledge will never hurt you, and more training would never hurt us. I have a hard time believing that doing ultrasound increased mortality unless the protocol that they had just delay patient care. Okay, then two more questions, just to take profit of your expertise. Do you think the point of ultrasound could make the difference also when you know the source of the shock, or it's just for when the cause of shock is undetermined? And then the other one is, do you think that the point of ultrasound could mark us the threshold in when to start to give inotropes versus only fluids? So the first question, if you have multiple gunshot wounds, don't do an ultrasound. And the only place where I would do an ultrasound with multiple gunshot wounds is to know if I'm going to start in the chest or in the abdomen. But somebody that is shot from head to toe, just go there and take care of the bleeding and ask questions later, right? We all know that. So it is, but that is in the trauma bay where we have a high volume of gunshot wounds, like here in Richmond or in Latin America. In most times when you have somebody that is blunt trauma, that has like many places that could be bleeding, or many other reasons of shock, or people that are older than 65, you might not 100% know that. You might think that you know, but you might not know the exact cause of shock. That's not, and then there's the people that are non-trauma, right? The sepsis, the people in the floor, the people that, you can have inadvertently ligated a ureter, and that's why you have low urine output. There's many reasons. Then in terms of ionotropes, absolutely. I think that if we can get as complex with the echocardiogram as doing measurements and doing what the cardiologists do and measure cardiac output, or we can be as simple as having a binary exam that will show you function of the pump, fluid status, and effusion. And in the simplest ways of an echocardiogram, you will see, do you need to intervene because of effusion? Do you have to give fluids because of hypovolemia? Or is your heart not working and you need ionotropes? So I think that the later answer, yes. Thank you very much. Thank you. I sent everybody the email, so if anybody wants to write me, the door is always open.
Thank you very much, Paula. Any other questions from the panel? Ioannis.
Paula, congratulations. It was a very, very nice presentation, fantastic presentation. I want to ask you something. I'm aware that in USA, the surgical residents, they go to ITU because it's mandatory to have some intensive care training about critical ill surgical patients. Those ultrasound scans, the POCUS, was it done by surgical residents in ITU or intensivists or both? Excellent. Both. Not only we have interns doing it, we have nurse practitioners doing it, we have attendings doing it. And we started with only attendings, but now everybody does it. The fellows, I think I have 2 nurse practitioners that are the best at it, that basically drive the boat. And but yes, I said this at the beginning, and I truly believe this to be true. I think if you don't have champions at every level, it dies, because it cannot depend on one person. this is what I want you to say to me, because it seems that the surgical training in USA, it's holistic. That means you have surgical residents doing intensive care and also be trained to ultrasound scan, and they collaborate with the intensivists and the other specialties. So it's like a holistic kind of training, which I think we miss in most of European countries. Thank you very much, and congratulations again.
My pleasure. Thank you.
Thank you, Paula. That was a great presentation, state of the art, and I know that you have stayed longer than you were planning to, so thank you very much for that. And if there are no further questions, then we'll move on to Ioannis and his case presentation. Ioannis.
Thank you very much, Jonathan. Let me share my screen. So I will speak quickly about the sound and the in for fluids and collections. I'm Ioannis. I'm one of the consultant general emergency surgeons with the upper GI and bariatric surgery interest in King's Hospital, and also I'm honorary senior lecturer at St. George's. I'm teaching you that, and it helped me a lot with my daily practice. As you all know, ultrasound scan in emergency surgery has many applications. You all know that can be used in trauma surgery, like abdominal visceral ultrasound scan, soft tissue, vascular, and interventional ultrasound scan. The ultrasound scan has many applications. We all know that. Specifically in UK, where I'm practicing at the moment, it is performed by ultrasonographers and radiologists. I'm mentioning that because it's very important. Those health practitioners are certified to do ultrasound scan and give official reports. In the other hand, point-of-care ultrasound scan is performed by accident emergency physicians, vascular surgeons, and unfortunately, in UK, it's not popular in the surgical community. The difference from my point of view about official ultrasound scan and point-of-care ultrasound scan is the official reports, but in the other hand, point-of-care ultrasound scan is a scan that is like an adjunct to your primary survey or your physical examination. I can say again and again that it's like your stethoscope, your modern stethoscope. I'm using it in my everyday practice in emergency surgery, and I'm facing some challenging situations like medico-legal things that you shouldn't write official report in the notes, but mentioning that you are doing a point-of-care ultrasound scan. And of course, sometimes it is very tricky because it cannot be accepted easily by other colleagues. So let's start with the case scenario 1. I don't know if you can hear me well, so we can start. So the case scenario 1. So those case scenarios are not fantastic scenarios, are real scenarios, happened to myself, and I acted like you will see later on. So they are realistic and real scenarios. So I was on call on Tuesday, in my on-call week, when there was a cirrhotic patient, obese, 65-year-old, with ascites, and this patient was under the medical team. Under medics, the medics attempted multiple times to drain the ascites, to do an ascitic paracentesis in the right side of the abdomen of the patient. Because the patient was obese, and it seems like they took a sample, but they, because of the multiple attempts, then the patient became septic for an unknown reason. And because they're worried for him, they transferred the patient to the intensive care unit. On Wednesday, very early in the morning, when I say early in the morning, I say 6 or 5 o'clock in the morning, they asked for a surgical opinion regarding a possible perforation because the patient was septic and there was an ongoing respiratory failure. It was obvious from their description that the ascites got more and there was increase in abdominal pressure. And also the intensive care asked for a acidic drainage catheter to be performed under interventional radiology. The reason they asked that was because they were concerned to try again to insert a catheter or puncture the abdomen. Because of the multiple failure attempts before, and because the patient was not very well. In my ward round, 8 to 8:30 with my surgical team, what I've seen the patient like this, quite unwell, and I've examined the patient, and the intensivist said to me, oh, we are still waiting for confirmation for interventional radiology. That means the interventional radiologist was not available. It was too early. He was coming after 9 o'clock until you will see what is in his list. They will try to transfer the patient to interventional radiology department and do it. So still waiting. So let's do the poll about what you will do next. So I have 7 suggestions. 1, request a CT scan abdomen pelvis. Reattempt paracentesis, exploratory laparotomy, bedside ultrasound scan and position a drain, request an erect chest X-ray, wait for interventional radiology to position a drain when they will become available, and or finally, conservative management with antibiotics and respiratory support. Please choose one. Oh, I can see that 74% bedside ultrasound scan and position a drain. That's very nice. Of course, not to ask the intensive care doctors to do it because they didn't want to do it. So what we've done, I made the decision at that time in front of the anesthetists that they were intensivists, that they were not very happy seeing me making this decision. They were surprised. I decided to do a bedside ultrasound scan of the abdomen. I've seen the fluid, and because of the ascites, it was obvious that the abdomen was full of fluid. And I've inserted a catheter with a Celtic technique, with a guide wire, like we do the central lines, under direct vision with the ultrasound scan and local anesthetic. 500 ml of clear acidic fluid was drained. And then I decided to save the fluid to the labs for leukocytes, white blood cells, and cultures to find out, of course, if it was infected. And we've asked for a gastroenterology opinion regarding the ascites and how to manage the ascites. Patients started to improve because, of course, the intra-abdominal pressure was decreased. Fluid did not show any high leukocytes, and there was no further surgical input. So, summarizing for this scenario, it seems that point of care ultrasound scan is fast, avoids delays, and especially if those delays can be life-threatening. It's safe, can be done under vision. If you know the technique, especially to put a needle inside an area where there is fluid, and you know the technique, it's safe and very quick. And it's, of course, a bedside procedure that you can do anywhere at any time. I will move to case scenario number 2. So in this scenario, there was a patient, 87-year-old female, presented to accident emergency with acute abdominal pain. She had a lot of vomiting for 12 hours, not feeling hungry, feeling quite unwell. Her past medical history included hypertension, liver cirrhosis, hypothyroidism, osteoarthritis on multiple medication, especially NSAIDs, no previous operations, and multiple admissions for recurrent urinary infections. I performed a clinical examination, and the abdomen was soft, mildly distended. There was generalized tenderness, but auscultation of the abdomen revealed bowel sounds present. Her blood pressure was 95/60, slightly tachycardic. Temperature was 37.3, and INR above 2. White blood cells 16.7, CRP 71, high inflammatory markers. And the urine dipstick that was performed showed 1+ of leukocytes, 1+ of protein, and no nitrates. As a surgeon, I had a decision to make. If you were the surgeon, what you will do? 1, request a CT scan, abdomen, pelvis. Request an abdominal X-ray and erect chest X-ray. Perform a fast scan. Conservative management with antibiotics and analgesia. Palliative care, just analgesia. Or do you think there is no need for a surgeon? We should ask a gastroenterologist or hepatologist to see the patient? Jonathan, do you have the poll? Yeah. Very good. I've seen many good kind of answers. Most of you responded as perform a fast scan, which is absolutely sensible to do. Or request a CT scan of the abdomen and the pelvis. So I made the decision to request a CT abdomen and pelvis. A fast scan was not the CT scan showed. Reported 3-inch abdominal fluid in 4 quadrants, no free air, thickened wall, small bowel, and superior mesenteric artery and vein were patent. The reason that I've asked for a CT scan in this case, I was thinking of fast scan, and actually I performed fast scan myself in accident emergency. I've requested CT scan abdomen and pelvis because there was a possibility of her having a perforation, really. She was taking a lot of non-steroidal medication because of her osteoarthritis, and I was thinking that possibly this fluid was from perforation from a gastric or duodenal ulcer. So this was what the CT scan reported. What you will do next, you have this report of the CT scan showing a lot of fluid in the abdomen, no free gas, no SMA, SMV, thrombosis. Will you do an exploratory laparotomy? Patient has high inflammatory markers, 37.1 temperature, tender all over the place. Will you do a diagnostic lab? Will you do a paracentesis of the abdomen and the ultrasound scan? A diagnosis, preventive management, send her to the wards with just antibiotics and analgesia. Decide that she's not for surgery, so palliative care, or no further surgical input. Ask a gastroenterologist, hepatologist to see the patient. So I've seen that many patients said, many people said about diagnostic laparoscopy, and the rest of you said paracentesis of the abdomen with an ultrasound scan. I want to believe that you say ultrasound scan because it's an ultrasound scan webinar, but it's nice to know, to discuss afterwards if actually your real decision will be that in any case. So I performed a point-of-care ultrasound scan, and of course I confirmed the fluid. I had the CT scan saying that anyway. And I decided to do a paracentesis under ultrasound scan guidance. Why I've done that, which was something again that the accident emergency doctors and my surgical trainees were surprised, was I wanted to see exactly what is this fluid that is inside the abdomen. And if you see this fluid and you send it for investigations, you can understand exactly what is the problem. Is it ascites or it is a perforation? So I was waiting to see what is this fluid. This is what the fluid came out. It looked like a peritoneal fluid from ascites. It was not pus. It was not like a thin kind of fluid with like you see in ascites. I've sent it to the lab and came back showing just ascites. So the decision was not to proceed with any surgery, continue with conservative management and antibiotics, and ask the gastroenterologist to be involved later on. Patients started improving. The next day, discharged after 4 days. So summarizing again, point-of-care ultrasound scan, it's safe. It can be under vision. Technique can save patients from laparotomy or laparoscopy. In this case, you said laparoscopy. We avoid that. And may facilitate early diagnosis, and it's a very useful tool for you in a bedside setting. So the question is, ultrasound scan useful skill for the emergency surgeon? I would say definitely yes, because it's an adjunct to the surgical practice. No operational cost, no radiation. We can use it as many times as we want. It's a dynamic scan, it's portable, and we can use it pre, intra, and post-operative use, no limitation actually. And of course, it's more sensitive for specific pathologies, as we said. I'm so keen of doing ultrasound scans. Like, this is what I saw in my morning coffee. It looked like a gallbladder with stones. So thank you very much.
Thank you very much, Ioannis, for that great presentation. I'm going to ask you the question. Paula Ferrada very expertly said that you can train anybody to do an ultrasound scan point of care, but there is a difference, isn't there, between a very non-invasive technique and beginning to put in sharp, pointy instruments into the abdomen. How much training do you think people should have before they start to do that?
Thank you, Jonathan. It is a tricky question. I'm not the right person to say how much training you should have, or Isidro should have, or Diego should have to perform this kind of procedures. However, I will say that globally, to insert pointy instruments like cannulating is an acceptable technique under ultrasound scan. And many practitioners, they use ultrasound scan to insert peripheral lines in obese patients that are very difficult to cannulate, or insert central venous catheters nowadays. Nowadays, it's unethical and illegal to insert central venous catheters without an ultrasound scan. So it's something that someone can learn very quickly. I cannot say a number; it will be wrong, dangerous to say about a number. But if you try starting with cannulation, which is not something dangerous, of course, having a proper course initially, trying in phantoms, trying to find a way to practice, and then start with cannulations, which is something not very dangerous, then you will be able to insert some small needles and try to aspirate something from collections. And I think you will not be dangerous.
Jonathan, may I ask something to what? Thank you, Ioannis, fantastic presentation. I think very real cases, so true cases, and I think all the audience will had appreciated your practical conclusions. in terms of questions about proficiency on interventional maneuvers, we do many more difficult things every day. It's only an issue of training, but training for some application of point of care ultrasound is very low, let me say, it's very simple. So to perform a DPA under ultrasound guidance, provided you have the principle of interventional ultrasound, is very easy and it's not a risky maneuver. In both cases you presented, not because I want to diminish the importance of the maneuver you performed, but honestly, was not a difficult maneuver, but it changed your decision both times. So why not to learn? This is the question. And honestly, the fact we are enough, but not so many attending the webinar, the confirmation that ultrasound is something that is still now considered something of ancillary. Is not ancillary, is essential. And we hope to be able in the next future to demonstrate that what Paula showed us or what the others suggested are something that enhance our proficiency and our ability to treat patients.
Jonathan, I want to say something like a conclusion to that. Mauro, thank you very much. In medicine and in surgery, my impression is that you don't have to do fancy things. You don't have to do something very dangerous or something that cannot be done before or something very skilled. You need to do the specific task, the specific move to help you with the diagnosis and help the patient. Maybe this is just put a small needle in the abdomen or auscultate the abdomen or just touch and feel the abdomen of a patient. As soon as you know when to do it, when is applicable, and help you with the diagnosis. So even simple things can be the best things that you can do.
Thank you very much, Ioannis. I think, Alessia, that's a very good point for us to move on to your presentation about whether POCUS is cost effective.
Yeah. Okay. Hello, everyone. So the topic that I was asked to talk about is the cost effectiveness of point of care ultrasound. So in order to be more practical, I will now show you the results of an observational study that we carried out on about 500 patients between January to 2018 and February 2020 in a hospital with a level 2 emergency and admission department. So the aim of the study was to compare point of care ultrasound with the other diagnostic exams such as contrast enhanced CT scan, X-ray, MRI, and ultrasound performed by the radiologist. So we then checked the effects of the performance of ultrasound instead of the other diagnostic exams in terms of changing in the clinical process and in the decision making and accelerating the clinical process and so the economic impact. So as you can see here, the ultrasounds have been performed both in the emergency department and in the general surgery ward to manage acute and chronic diseases of the abdomen and thorax. So at first, we set up the total cost of each diagnostic exam. So every exam has variable and fixed costs. The first ones depend mainly on the time needed to perform the exam. So here are the average time that we calculated to perform our exams. So as you can see, the bedside ultrasound requires about 8 minutes to be performed instead of the other exams that require many more minutes, mainly because of the transport, of the necessity of a transport of the patient towards the radiology suite. And so because of the involvement of other medical and non-medical personnel, which involves other costs, obviously. Then the fixed costs depend mainly on the initial purchase of the machines and then on the maintenance, but also on the total number of exams that are performed per year with a single machine. So these are the costs of a single exam that we calculated in our hospital. So as you can see, we have X-ray, ultrasound in radiology, and bedside ultrasound as the cheapest ones with about 14 euros per exam. But X-ray and bedside ultrasound have pretty as much the same cost, but X-ray has more variable costs because of the, as we said, of the necessity of a transport of the patients and the involvement of other personnel. But X-ray has also lower fixed costs, which is the exact opposite for bedside ultrasound. So then we set up the benefits that resulted from performing bedside ultrasound instead of the other exams in terms of length of hospital stay and hours of operated room that we managed to save. So as you can see here, we managed to avoid about 100 days of hospital stay and about 23 hours of operated room, which means a total save of about 270 euros per patient. So the previous ones were actual results. These ones that you can see here are results that have been weighted on the population and on the type of hospital in which the study has been carried out. But just to be simple, in this graphic, you can see that the performance of bedside ultrasound instead of a contrast and CT scan allows to save about 15 euros for the exam itself and about 350 euros for the clinical benefits that come from the performance of the ultrasound. In this graphic, you can see that the performance of bedside ultrasound instead of all the other exams allows us to save about 280 euros per patient. So these can all be translated into a total saving of more than 130,000 euros in just about 2 years. That is the time of the study. So then we went further and evaluated the potential savings that we could have had if we had performed ultrasound instead of the other exams or before the other exams whenever it was not done. So as you can see here, we could have saved 56 days of hospital stay more. So in the end, we made a perspective of a routine use of bedside ultrasound with a projection of savings at a national level that have been calculated for the years 2060 and 70s about the DRGs that are the tariff of services for hospitalizations for the management of general abdominal pain, such as in acute diverticulitis and acute appendicitis. But just to make you an example, this is a projection of the savings that Italy could have in just 2 years that amount to more than 11 million euros in performing ultrasound instead of the other diagnostic exams. So after this all, I will now leave you with just a simple question. So just thinking about the low cost of a full training in ultrasound, such as the music course, do you think that could a full training in ultrasound for all surgeons be a worth investment for every hospital? Thank you.
Thank you very much, Alessia, for that very thought-provoking presentation there. How much do we think it would cost to train all of your surgical residents in Italy in order to be competent in point of care ultrasound? And that's a question that Mauro can answer if he wants to. Because I knew he wasn't far away.
Good question, Jonathan. So you know that there are some courses. Paula, I don't see her connected yet, but she presented for the limited transthoracic echocardiography a very short course. I don't know the cost of this course, but it's very short. And you know, there's like in ESTES, we developed it with some of the panelists too, a course which is called the music course, modular ultrasound ESTES course, which is an ongoing project. And this is something that is tailored for surgeons. And the cost, for example, for attending the 4-module course, actually is the format of the music, is no more than 450 euros. So it's not so much. It remains the training, the proctoring after the course, but this could be done with the help of the local faculty, with the help of some radiologists you can find. And in any case, if you perform ultrasound, you become more and more proficient day by day. It's not to be rough, is the truth. It's like surgery. You have to have trained at the beginning and then you have to practice. And the difference between surgery and point of care ultrasound is that you cannot do something you are not able to do in surgery, because you do a mistake for sure, a technical mistake. In point of care ultrasound, if you maintain your brain connected to your hand and to your clinical question, you can say sometimes, yes, I am sure. Now I got a finding and I can go ahead with the finding and with the decision thanks to ultrasound, but you are not sure, you do not harm your patient, and you can go ahead asking for an help by another colleague or doing another imaging technique. So you don't harm your patient and you improve and you can save time, you shorten diagnosis. The 2 cases of Ioannis were paramount, absolutely. And I think that this is something that we have to take into account, and we finally were able to finalize this kind of study Alessia showed you, which is probably the first demonstration that you can save money, and all the advantages from the economical point of view were obtained in a team where only 2 or 3 surgeons really performed point of care ultrasound. Imagine the amount of saving if you are able to train half of your team or 70% of your team. And the money for training is there. If you do, you save money. You have money to invest for training. If you can share, let we share the screen. Yes. Pardon. Dov'è? Okay, only for showing you that what is music for those who don't know it, is really taught for general trauma and acute care surgeons in any situation for any individual skills and levels. So you can pick up what you need and you can train step by step, improving your skills. It's a very practical course with a lot, it's a blended course with a e-learning part, with a practical live part, but today this is at the moment, this is a problem, with personal, and you see, these are not artifacts or sorry, are not pictures that we put there for convincing people, because the probe is in the end of the participant, not in the end of the coach, because this is very important. And finally, you also have the possibility to train on phantoms. These are not all the 4 pictures you are seeing are not real patients, but these are phantoms for appendicitis, for bowel loop, for gallbladder. So you can even get in your eyes pathological situation simulating what you have to search for. So I think that is a player for stay with us in the future, and maybe strengthening some collaboration, for example, with the overseas colleagues that on the side of intensive care unit, for sure, intensive care, surgical and surgical critical care are for sure more advanced than we are.
Thank you, Mauro. One thing which we haven't covered, and I know isn't covered in the music course, is the use of point-of-care ultrasound for testicular torsion, a time when you can't use a CT scan and you want a rapid diagnosis. Do you think there is a role for point-of-care ultrasound under that circumstance?
I don't know what was the feeling of the others. Music instructor are connected, but normally the torsion, testicular torsion is first of all a clinical diagnosis. Yes, you could find some decreasing or changing in color Doppler pattern, but this is a more advanced application. So we have to, what you have to search is an enlarged testis and a retracted testis, and these are both clinical diagnosis. So color Doppler has a role, but color Doppler is not a basic application. You risk to be wrong if you rely on that and you are not an expert.
Okay, thank you very much for answering that question. We'll just run around the panel. Does anybody have any comments they want to make at this stage before we bring the webinar to a close?
Jonathan, I want to comment because I've read a very good comment on what is the practice. One of our attendees wrote down about what is the current practice in North England, and especially I think it was Sunderland Hospital in Northeast England. They said that they agreed that POCUS emergency department consultants and acute medics, they will put a report just like the ultrasonographers do. I think this is a very brave decision, but it's very good because it gives the POCUS an importance and validity. However, in general, in practice, when I think from my point of view and what I'm doing in my everyday practice, I'm very careful what I'm documenting because it's an official document. It goes with the patient notes. And I think the right way to document, especially in UK, is to write down point of care ultrasound scan was performed by surgeon, and the differential diagnosis is that clinically, and together with the ultrasound findings, I agree that this is the differential diagnosis and will proceed further with scanning or exploring or whatever. So you need to be crystal clear what you document about your findings, who did it, where it was done, by whom. And then you are covered. Nobody will say why you did an ultrasound scan or you are not an ultrasonographer or radiologist. As soon as you use it like a stethoscope, nobody will say to you, why you use your stethoscope? You're not a cardiologist. I think it's the same question. As soon as you document something and you are crystal clear. Afterwards, there will be always someone who will doubt your clinical decision anyway, so don't worry about that.
Yes, I think that's a very important point, Ioannis. And really what you're doing is you're using your point-of-care ultrasound as part of your basic clinical skills. You know, you examine an abdomen with your hands and you examine it with an ultrasound probe. The findings that you have, if they all make sense, are all relevant findings and they will help you inform your own practice. So I don't think that there should be a problem with doing it. Okay, anybody else want to comment from the panel?
May I say something? I just want to point that with the cases that Ioannis present, I think we will see, and now we are seeing, that ultrasound is also changing our way of approaching the patients, our way of teaching how to approach the patients. I remember when I learned to do a paracentesis, it was a blind procedure. And I was always wondering if I could puncture some bowel loop or whatever. Nowadays, it's our obligation to use the ultrasound for almost every interventional procedure. And we can see it's much more easy and much more safe to do it with the ultrasound.
I think the role of ultrasound guidance in a lot of things that we used to do blind when I was much younger has shown the role, the value and the importance of ultrasound at the specific point of care. A question, really a comment from the audience, is that very often the point of care ultrasound pictures are stored on the computer systems together with the formal radiology images. And of course, I was going to say it, but I thought better of it. But as it's been brought up in the Q&A, our radiology colleagues don't always get things right. And we are the first ones to question some of their reports sometimes. So it's only to be expected that they will do the same to us sometimes. And I think on that point, it's probably a good position to bring the webinar to a close. Let me share my screen. What we are going to do next 2 weeks' time is to have a webinar on the management of periarticular injuries around the knee. And then we will be having a break so that we can clear the decks in time for the virtual ESTES week, which will take place between the 25th and the 30th of April. During that week, there will be 30 hours of state-of-the-art lectures and presentations, which have been put together by the various sections within ESTES. I hope that you've enjoyed it. I hope you'll join us then for that. I'd like to take the opportunity now to thank our great backstage crew consisting of Alan Biloslavo, Diego Mariani, Hayato Kurihara, and Mauro Zago, and our great speakers this evening, Daniel Dumbrava, Andrea Casamassima, Paula Ferrada, Ioannis Gerogiannis, Alessia Malagnino, and again, Mauro Zago. I hope you've enjoyed the webinar and look forward to you joining us again very soon. Thank you. And on behalf of everybody, goodbye.
Bye.